Okay, good afternoon, everyone. Thank you for joining us. My name is Mariah. I'm with the Arizona Center for Rural Health, and this is the State Office of Rural Health webinar series. A few notes as we get started. The audience will be muted during the presentation. However, we encourage you to use the chat function for any questions that come up, and we'll try to address those questions throughout. Lastly, please fill out the post-webinar survey. This is really important if you want continuing education units. If you don't complete the survey, we're unable to award it. That link will automatically pop up in your browser, and we'll send it in the chat as well. And then lastly, there is going to be a recording, and that will be posted on our website a few days after this presentation. And we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through educational offerings, partnerships, and community service. And I know this is a lot of information on the screen, but overall, I just wanted to point out that we are offering continuing education units for this webinar. None of the planners or speakers have any conflicts of interest to disclose, and in order to claim those units, you will have to stay for the entire presentation and fill out the post-presentation webinar series. So with that, I am going to stop sharing, and I will hand it over to our first speaker. Leila, will you give us an overview of what this looks like?
Sure. Can you hear me now?
Yes.
We
Got
can,
it.
yes.
Okay, great. And you can see the slides.
Yes, thank you.
Perfect. Perfect. Thanks. Technology so far is on our side. Well, welcome everyone to our presentation today. We have a lot of information to share, so I'm just going to get started. I'm going to give a brief introduction on HR1, and then we have some other great panelists to continue the discussion today. So HR1, more commonly known as the One Big Beautiful Bill Act, OBBBA. This is a picture of the signing in July of this past year. It's a very comprehensive long bill. It's 870 pages. And the legislative history here, you can see it was first, a version of it was passed first by the House in May. And then in July, amended version of it was passed in the US Senate by a very close vote. The tiebreaker was actually from Vice President J.D. Vance. And then the House passed a motion to agree to the Senate amended version. And then Trump signed it July 4th. So that happened very quickly from the Senate version to the signing of the bill very quickly in July. And prior to the passage of the bill, a poll here you can see from Pew Research showed that the public opinion was not very favorable for the provision of, the provisions in this budget reconciliation bill. Only 12% strongly favored and 37% strongly opposed. So public opinion wasn't favorable to many of the provisions in this act, and I'll explain some of those provisions in the next few slides. The Congressional Budget Office gave some updated estimates. They gave some initial estimates, but they provided an updated estimate after the amendments, some of the changes to the act, to the final version. And CBO estimated that the actual result in a net increase in the unified budget deficit totaling 3.4 trillion over the time period 2025 to 2034. So obviously a big impact on the deficit. Now looking at some of the health provisions in the OBBBA. Looking at some of those in detail, the KFF has estimated that over 15 million people will uh, become uninsured um, by 2034. And that's due to a number of factors related to provisions in the Act. In particular, Medicaid changes. Uh, in the Act, there are changes to Medicaid requiring community engagement requirements, more commonly called work requirements. There's also provider tax limits, and that's the mechanism that many states use to fund the state portion of Medicaid. There are changes to marketplaces, the ACA marketplaces. Some of the changes are a result of the Act codifying a proposed rule that was proposed back in March of this past year by CMS that included changes to the marketplaces. And one example of those changes is a shortening of the enrollment period. Other changes in HR1 that are not from the proposed rule include pre-enrollment verification. So those are all analyzed here by KFF and the impact that they have on the number of uninsured people. And also the expiration of the ACA enhanced premium tax credits. Those will expire at the end of this year if not extended. And those tax credits do help individuals pay for the insurance off the marketplaces and pay for the premiums. So by some estimates, some individuals may see their premiums double if those tax credits are not extended. Looking just at the landscape here across the country, you can see the impacts of the federal Medicaid cuts. Arizona and other states could have severe cuts in the enacted reconciliation from the enacted reconciliation package. Now, the timeline of this. So some of these provisions will be effective immediately. And there's other health-related provisions that will be implemented later. For example, the community engagement requirements, the Secretary of HHS will propose or issue a rule with details on many of these community engagement requirements in 2026, and states will have to implement this by January 1, 2027. So there are timelines in here. You can see that some will be effective immediately and some will become implemented later on. This shows some of the examples of what those work requirements will look like. Some qualifying activities, mandatory exemptions. We know from states that have implemented work requirements, such as Arkansas, that the process, the technology to verify that you are qualifying with these requirements can be very challenging and can be a barrier based on just having access to the internet or a computer and the technology to submit all of the requirements. So I think some of the other panelists may touch on this later on as well. And then also included are some provisions related to SNAP, the Supplemental Nutrition Assistance Program. There will be some cost sharing programs with states, and there's a change to the ages for work requirements for SNAP. So the age used to be the higher upper limit used to be 59, now it will be 65. Also will be included in the past, there was no requirements for individual or for parents who had children under 18 who were in the SNAP household. And now the exception will be a parent or other member of the household with responsibility for a dependent child under 14 years of age. So that exception has changed. Also, some exemptions for veterans have been impacted by the act as well. So changes there to the SNAP program as well that will impact individuals across the country. There are some opportunities especially for rural communities. The Rural Health Transformation Program funding, which will be discussed later in the presentation, a one-in increase for the Medicare physician fee schedule, and a permanent extension of the safe harbor for high deductible health plans to offer first dollar coverage for telemedicine. So just a few highlights there. And I am now going to pass it to Professor James Hodge to continue this discussion and focus some of the potential challenges.
Leila, thank you so much for raising those specific issues with us, walking us through some of the most significant, without doubt, major impacts from a health-related perspective arising from OBA as passed, as you see on July 4th of this summer. It's pretty sobering. We've worked hard as a nation for the last 20 years, essentially, to try to raise up the level of persons in the United States who actually have access to basic healthcare services through good insurance. It's taken multiple pieces of federal legislation, highlighted by the Affordable Care Act, supplemented by the Inflation Reduction Act through President Biden, to actually get us to a threshold where literally we're at one of the lowest rates as far as uninsured populations in the recent history. And now OBA looks to reverse a good portion of that. It's sobering. It's sensational. And it's going to hit Arizona big time, as you'll see and hear a little bit more from Dan and from Will here momentarily. But I've got at least some good news for us related to it. It's challengeable. And just like the Affordable Care Act and the Inflation Reduction Act and every other major federal piece of legislation that has such magnanimous impacts on health, this bill will be challenged, is already being challenged, and is going to be subject to some additional modifications, I would project, before much of the harm might occur in regards to Leila's very well laid out timeline there. So let me just give you a little flavor and sense of what some of those legal challenges may be forthcoming, and give you at least hopefully a reasonable profile to say that if your goal in rural health, like it is all our goals, to assure access to basic health services through good insurance, through access to the types of programs and initiatives that make better health possible for persons in rural parts of Arizona, we might see some positive changes there in addition to that $50 billion infusion that Dan and Will will talk about directly at rural health related initiatives. What are these challenges looking like? Well, first of all, from a legal perspective, let's be conscientious. Some challenges are now pure policy statements, and some are real legal challenges filed in court and other arenas. Some have legislative backing. All of it's timed about what Leila was talking about regards to the implementation issues. There's timing relation to litigation challenges. You don't get to bring litigation challenges to things that aren't yet in place. And so we're going to be watching some of that over the years to come. What we do know presently, everything that is in place in regards to OBA already has been challenged legally. Let me give you a good example. There's a provision within the bill, considerable impact in specific arenas, that disallows any particular health provider participating in Medicaid and otherwise who has had in their past or currently engages in some level of abortion or a type of reproductive health care. Let's be clear, Medicaid's never been about, at least at the federal level, funding abortions, and certainly Medicare and such. It's never been about that. But the reality is some providers, like Planned Parenthood, have services that are valuable for persons in rural and or other settings to achieve. And this bill, this OBA provisions, literally terminates that. You can't be in the business of providing that type of care and get any funding through these specific mechanisms at the federal level. That's a big change, and it got challenged already in multiple federal litigation brought in federal courts across a couple different jurisdictions. Some early challenges to that, just to note, were successful. So we actually saw a court in Massachusetts shut down that specific program for several months. but it got before a court of appeals, and that court of appeals has stayed that injunction. That's legal talk for put that injunction on hold while we actually assess and digest fully the full range of potential legal issues out there. What's important to note, though, is nobody's taking these major health impacts from OBA straight up. The challenges are forthcoming, and even on that initial sort of concern, the challenges have arisen. States and others have shown up with multiple different challenge mechanisms. And then I'll get to federal legislation. Several states have already made it very clear, like New Jersey Governor Phil Murphy has issued an executive order essentially saying in his state, something you might see replicated in Arizona soon, we are going to study and assess and find every way possible to limit the impacts of OBA's reductions in Medicaid enrollees and or other particular fronts. We're going to seek every angle we can in regards to that particular executive order. That's pretty powerful stuff when you think about what a state can do in the backdrop of so many of these provisions hitting state-based Medicaid populations, these work requirements Leila was talking about, the sort of disenrollment perspective. To see a governor actually make it clear we're studying it now before it hits us hard to actually assess exactly what we can do. You'll see other states fall in line with that. And I dare say Governor Hobbs may be looking that direction too, although I have no internal information to that same accord. There are other types of legal grounds that we can be using and thinking about now to challenge some of the most onerous issues, like Leila was talking about with these work requirement that we've instituted and tried a little bit in Arizona, at least in experimentation. It's no experiment soon. Every state must impose work requirements for Medicaid populations. Here's the deal. The states that Dept tried that during the first Trump administration, like Arkansas and Kentucky, Georgia tried it. Georgia still has a program in place, but the other states don't, because those specific work requirements did get legally challenged and got shut down by courts. They violated key provisions of the Administrative Procedures Act. Without getting to the legal sort of arena around that, there are specifics you have to do well in regards to implementing that. And they violated certain constitutional norms around due process. What's important to note is not that we would foresee the same challenge being successful in regards to a national recommendation or requirement pursuant to OBA for that, but it's forthcoming. Nobody's going to take these provisions hands down. There will be challenge on that front. Now let's get real briefly, before we turn it over to Dan and Will for their expert assessment of impacts here in Arizona, let's turn real briefly to federal legislation. Now, what's the deal with that? We already found federal legislation was passed in July, and it's OBA, and that's the law of the land, and that's what we have to live with and work with for the moment. Wait a minute. We have something upcoming in the United States that's annual procedure, and it's about not balancing this budget. It's about keeping this government running at the federal level. What was just introduced not long ago through Democrats at the Senate is an important measure that actually could start to play into some immediate fixes for OBA's related damages to come. It's called the Continuing Appropriations and Extension of Other Matters Act of 2026. It's a fancy way of saying, here's our response from a Democratic platform to what we saw done through House Republicans and President Trump in regards to OBA. And what would it do if it gets passed? It will withdraw Medicare or Medicaid work requirements. It will reinstitute ACA subsidies. It will really reverse the exact damage that OBA seeks to do. That's exactly what's written into the bill, and it's precisely what Democrats are pushing for to keep this government open. It's what they're demanding. Whether or not this will be successful, well, that's going to be worth seeing. That's going to be a real uphill climb, but I'm hopeful that even in Congress, as some of these sort of most significant impacts are starting to arise and Congress starts to feel out what's coming, what's going to hit the United States pursuant to some of these critical choices, this bill gives an opportunity for the Senate and then the House to actually negotiate again whether or not this government's going to stay open, because Democrats don't appear ready to back down from these particular initiatives. Now, we'll find out precisely in the weeks to come which of these channels, from a legal challenge perspective, may be successful, whether it's litigation, whether it's executive action, whether it's actual new legislation through Congress or new state legislation that actually works around some of these critical concerns. What I want you to take away from this brief sort of assessment and discussion with questions forthcoming, don't accept what you see in OBA as fixed. There is room to challenge, and I dare say those challenges could be successful as we go forward. Now, without further ado, let me turn it over to our great colleague, Dan Derksen, for more on OBA's impacts here in Arizona.
Great, thanks, James. Let's see if I can get my presentation pulled up here. Great. Mariah just wrote in chat, we had a little technological issue with the chat function. And so that should be fixed now. So hopefully we'll start seeing some questions from you all on some of the content that's been delivered so far by Leila and James. And what I'd like to do is really hone in on how HR1 really affects Arizona, especially in rural areas. One of the things I'd like to talk about is of the 870 pages that Leila mentioned of this bill, 17 of them are quite good, actually. I'd like to know who authored them of the folks, but the Rural Health Transformation Program is one of those things that I'd say this is a huge opportunity for Arizona and other states really to help transform some of the challenges that we've had in rural areas of our states over the next 5 years. What's written in the bill is $10 billion a year for 5 years. Now, as James just alluded to, there's this little continuing resolution that includes the discretionary funding for funding this $10 billion a year, or $10 billion for this fiscal year, and however long this continuing resolution lasts for. So we'll know that hopefully in the next couple of weeks, or we risk a government shutdown, because the new fiscal year federally starts October 1st, and they have to get this done before then. So when you look at that Rural Health Transformation Program provision, and I encourage you to do that, half of that 10 billion in this fiscal year will be divided evenly between states. So if my math is correct, that's 100 million per year per state. And that's really one of the larger investments that's been made in decades in the rural health infrastructure, potentially. The Centers for Medicare and Medicaid Services is overseeing this provision. So they're the ones that the federal agency responsible for this. They just released their notice of funding opportunity to states on September 15th. So this just came out. It's something like 125 pages. And as is usual with these funding opportunities, the notice of funding opportunity is 125 pages, and yet the narrative can only be 60 pages or less. So states are going to have to be very judicious and efficient in what they include in their plan. Now, states really have a very short turnaround in getting this back to CMS for approval or denial. And they have to get it in by November 5th. So in the scheme of things, given the amount of money, $500 million over the next 5 years for Arizona, and then another $5 billion that CMS will decide how it's allocated based on some of the numbers, the state's number of individuals living in rural areas compared to the national average, the number of rural and critical access hospitals, the number of federally qualified health centers in rural areas. So there'll be another chunk of money that a state like Arizona would be eligible for if they make a persuasive argument for that funding in their plan. The governor's office, led by Megan Kramer, is my understanding, who will lead the plan development. Already, our state Medicaid program, the Arizona Healthcare Cost Containment System, or ACCESS, is leading some of the efforts in stakeholder engagement and community engagement. I was invited to attend one on a tribal listening session last week, and I know that the governor's office, through various means, has reached out to other things like the Arizona Hospital and Health System Association and our state's Primary Care Association, the Arizona Alliance for Community Health Centers, and many others. The ACCESS program has posted a request for information. It's an RFI is the acronym for that. There'll be a lot of acronyms. I tried to translate them on the bottom of my slides, and we'll publicly post this as well. So that's another means by which the state will gather information of what should be included in the plan. And then CMS will have a very, very tight deadline to review what I presume will be 50 state plans that will be submitted, and they have to approve or deny a state's plan by December 31st of 2025. So you can see the urgency of this being done for states. What I would refer you to, if you write nothing else down, this is one either take a screenshot of or write it down, but please do take a look at our Center for Rural Health website. We've been trying to compile a series of tools. The Arizona Center for Rural Health houses Arizona's State Office of Rural Health. You know, every state has a state office of rural health. We're one of about 10 states that it's housed outside of a state government agency. And so we really see our role as, well, how can we really help the state with data and information, with tools to make sure we submit a very strong plan to CMS, get it approved, and really get the resources we need to help transform our rural health system. So you can see some of the tools on there. The actual notice of funding opportunity that just came out on the 15th of September, that PDF is in there. The state Medicaid program, the access program request for information, and there's instructions on that. That's basically your opportunity to give input, or your organizations or who you represent. And then we did an overview, like we're doing today, of some of the things related to the Rural Health Transformation Program and that policy brief. And then other tools that we think will be helpful for the state to submit a strong response, including a summary of our state's 17 critical access hospitals and our rural health clinics and other elements of the rural health safety net that are so important for preserving, and then hopefully through this process, enhancing our ability to provide health services in our rural and tribal communities across the state. So with that, I'm not going to go into a lot of the details of what's in the policy briefs. I do encourage you to look at it. One of the things we spend a fair amount of time on is really looking at our health workforce and specifically our physician workforce. There's other tools that we'll be adding as we finish them and post them publicly for your use or for the use of the state as they draft their response. This is something I try to present especially when I present to people back east, like CMS is based out of Baltimore. You know, they may not quite understand. You know, we're the 6th largest state in land area. It's a huge geographic area. You could fit all these New England states inside of it and still have enough room left over for other things as well. But very large area, you know, outside of Phoenix and Tucson, Maricopa, and Pima County, our 13 other counties are quite rural and in many cases really fit the definition of frontier. One of the policy briefs you might look at is our attempt to really look at what might be used as criteria for a rural definition using updated data on the rural-urban commuting areas, the RUCCAs, that the Federal Office of Rural Health Policy has been using for prioritizing grants that focus on rural areas. They had been using the 2010 data. We used the updated 2020 data and tried to translate that for what that means in Arizona's rural areas. The other important thing I think to look at is that 27% of our state's land area is tribal. And if you look at some of the highest vacancy rates as far as health workforce, if you look at some of the health outcomes we need to do better on as a state in these rural and remote areas, this is an area I think that needs some focus and attention as we put together, as the state puts together the Rural Health Transformation Program. I include this, we just updated and just posted our annual Center for Rural Health annual report. And part of that annual report is the safety net map. In this case, we're focused on those entities outside of the larger metropolitan areas, the location of the 17 critical access hospitals and states in the state, and the 54 rural health clinics, including the 31 that are critical access hospital affiliated, the 26 community health center systems in the state, and the 175 or more federally qualified health centers in the state. And then importantly, as I was just alluding to, both the Indian Health Service sites, 2/3 of our sites are tribal operated, Public Law 638 tribal operated sites. And so these are the areas that I hope receive attention to the area. Often is the case, we have to balance the wonderful care that can happen in large metropolitan areas like Phoenix and Tucson and Flagstaff. But this is really, this Rural Health Transformation Program is really focused on those most vulnerable to loss of Medicaid coverage in the state in our rural, tribal, and border areas. We talked a little bit about this when Leila gave her presentation, but we had a record enrollment in our Affordable Care Act marketplace. And as James mentioned, that the subsidies that make that much more affordable for a significant number of those enrollees, and a record number in January, rely on the advanced premium tax credits to make it affordable. Those will expire without action. I'm hopeful that we can include that in this continuing resolution so that health insurance coverage to the Affordable Care Act, it continues to be attainable for those individuals who depend on it. Otherwise, some of the estimates say that the premiums could double to triple. And you're already seeing some of the posting of that if this isn't extended. So those expire in December. They need to be extended through this continuing resolution. By my analysis, about 150,000 Arizonans would lose coverage because they just can no longer afford that skyrocketing increase in their premiums. And then the federal cuts, again, Leila had this in one of her slides, but those don't happen until after the midterm elections. So these wouldn't start really till January 2027. But doing twice a year eligibility, enrollment, and redetermination processes will, and this is all by the Congressional Budget Office, at how many people would lose coverage. And there's estimates that range from 250,000 to 450,000 who are currently enrolled in our state Medicaid program access would lose coverage because of these more onerous, difficult to implement, number one, work, demonstrating work requirements, and then the twice a year redetermination process. So when I look at this data, I'm thinking that by 2027 to 2028, we'll go back to the days of well over 1 million uninsured Arizonans. We're at about 750,000, a little less than 10% of our population is uninsured today. We'll almost double that in the coming years with these requirements being enacted around work requirements and then twice a year redetermination. And what does this mean? I know this is a little provocative, but I think this is important as well. If you look at what qualifies the top 1% of income in the United States, it's averages about 916,900. If you divide that by 40 hours a week times 52 weeks a year, that's 2,080 hours. That's about $440 an hour, which is about 58 times the eligibility threshold for where the federal poverty limit is for an individual. And if you look at the tax benefit as part of H.R. 1 to the top 1% of income over 10 years, the cost for that is about $1 trillion. The Congressional Budget Office estimated that the savings of cutting Medicaid over 10 years is almost $1 trillion. But in my view, you really don't save money by throwing people off of coverage, whether it's Affordable Care Act marketplace or Medicaid. you're just shifting those costs from the federal government to individuals, to health systems that will undoubtedly have to shoulder a higher burden of charity care and uncompensated care. And if you look at the tax benefit to the top 1% of income earners, that value over the course of a year is about $66,000, which is about 3 times the Medicaid income threshold of $21,597 at 138% of the federal poverty level. So really, if you look at it, there's no way around this, that you're financing an enormous tax break to the top 1% by really taking benefits, public benefits, away from those who need it most and the lowest income population in our state. And with that, I'm done. I'll make sure, Mariah will make sure that we post all this on our website, and I'll stop sharing. And I think there's a few questions to answer, and I think Will is going to provide some color commentary in his orange shirt there.
I wore my orange shirt on purpose because I'm doing color commentary. Okay, so I just want to emphasize a few things from the presentations, mainly around like what the timeline is for the various provisions. So the first thing that's going to be implemented as a part of this bill, now law, is we're losing our SNAP education program. So many of you will be familiar with SNAP being what we used to be called food stamps. There was another part of SNAP called SNAP Education, and that was a program implemented through the state health department, but also through their contractors to get out into, a lot of it is in rural communities, but it's across the entire state, where the idea is to help families who are getting SNAP benefits to make healthier choices for their families. So educating people about using double up food bucks, for example, for with their SNAP benefit, how they can go to the farmer's market and use their SNAP benefit for fresh fruits and vegetables. Even so far as to helping people with healthy recipes for their family that's not ultra processed foods. So, Secretary Kennedy keeps talking about, oh, blah, blah, blah. We want to, help with chronic disease prevention. Well, this precisely is the opposite of that. He's expressed support for this entire bill. So SNAP education is leaving in about 2 weeks. And so as we speak right now, the state health department is, I'm sure, going through a process of laying people off who worked on the SNAP education program, canceling contracts, and just basically shutting down the decades-long SNAP education program, which is, again, designed to encourage people to eat healthier foods with their benefit, not just with their benefit, because SNAP isn't all their food. It's just a supplemental to it, but it taught families like how to prepare healthier foods, which are often, by the way, at a lower cost than the ultra processed stuff that you see at the grocery store. So that's the first thing that we're losing, not just in Arizona, but across the entire country. SNAP education pretty much finished. The next, and Leila covered the advanced premium tax credit a bit, and Dan, you did too. When the Affordable Care Act passed back in 2010, it had advanced premium tax credits so that people under 400% of poverty could have some relief from those premiums when they buy their insurance on the marketplace, and that made the insurance more affordable. But as the pandemic came, Congress offered additional resources for that advanced premium tax credit. So, for example, the Inflation Reduction Act and the American Rescue Plan Act provided, it relieved a little bit of the cliff. So people under the original Affordable Care Act premium benefit, that all stopped at 400% of poverty, which for a family of two, I think, is about $80,000, something like that. The enhanced advanced premium tax credit gave some relief to even those folks and capped your premiums basically at 8.5% of your income. And so that provided that relief, but also it had other enhancements to that advanced premium tax credit to make premiums more affordable on the Affordable Care Act for everybody. Now, that is scheduled to end on December 31st of this year. And Dan, you mentioned that there's some debate going on in Congress about, can we extend that? The provisions that were in ARPA and the Inflation Reduction Act, is it possible to extend that benefit to families? Yes, it's possible, of course. Will they do it? We'll see. I expect maybe to see some horse trading on this in Congress, where the Republicans are like, well, our soybean farmers are hurting big time. They won't blame the tariffs, but that's why they can't sell their soybeans, because China's not buying them. And you could see like some horse trading going on where farmers get some welfare to the tune of 10, $20 billion for the crops that they are sitting in the silos in exchange for maybe some advanced premium tax credit. That's the kind of dirty mess that happens in Congress. Dan, you're smiling because you worked, I know, in New Mexico in Congress, and you know how dirty it gets with the horse trading. So it could be that the advanced premium tax credit enhanced part of it stays. But if it leaves, just remember that it's not the subsidies completely that are leaving. It's the enhanced subsidies that came as a part of the provisions in Inflation Reduction Act, and also the ARPA Rescue Plan Act. So that's what's at risk immediately. The next two things that I'll just highlight and then I'll stop talking are in January 2027. And that is the Medicaid work requirement or community engagement or going to school. And that's January 2027. So I think state Medicaid agencies need to operate under the assumption that that's going to stay. And what is really important throughout 2026 for Medicaid agencies, including Access, is to get their computer systems in order with a usable system that works on Edge and Chrome and everything else, so that when the time comes for Medicaid members to turn in proof that they're in school, that they have work, that it's a system that's workable for everybody. Because one of the ways, and the Congressional Budget Office contemplates this, that is people who are in school or who are working will lose their benefits because they can't operate the computer system that their state Medicaid agencies set up to ensure that they meet the qualifying requirements of what we call work requirements, but also you could stay in school for that. So it's not just the law itself. States do have some role in minimizing the impact of this, but they have to make that investment in 2026. That has to be now. You've got to get your computer programmers. If your server's on an old 20-year-old Oracle server, like, you need to be buying a brand new server that can help accommodate people on the different browsers. Because, like, for example, one of the things we saw during COVID is you could make your appointment for your vaccine on Chrome, but not Edge. That kind of stuff trips people up. And so, there's administrative things that are more urgent in 2026 for these Medicaid agencies, including Access, so that when the time comes for people to report that they are not, agencies in themselves are not becoming a big barrier. Now, I'm confident that Access wants to do the right thing in our state. What they need to do is resource it, make sure their computer systems work, get talented programmers in there, so that, and then beta test it, alpha test it, beta test it in the field, so it's ready to go next October, 3 months ahead of the deadline for implementing. So that's that part of it. I want to touch on SNAP for a second too. The changes to SNAP, Supplemental Nutrition Assistance Program, begin in January 2027. And the way the feds are booking the savings on SNAP is they're looking at state agencies that administer SNAP. In our state, that's the Department of Economic Security. They're looking at how those agencies, their error rates of those agencies when it comes to SNAP beneficiaries. So, for example, if someone qualifies for SNAP and DES says, oh, no, you don't qualify for SNAP, that's an error. It's also an error when you give benefits to somebody that doesn't qualify for those benefits. It's also an error when you give somebody too much money than they're entitled to or not enough. So the way the feds punish states in the SNAP program, or will begin punishing them in 2027, is looking at the error rate within their state agency's SNAP program. In our case, that's at DES. Arizona's error rate in 2024 at DES for the SNAP program was 8.5%. That translates under HR 1, that translates to about $150 million of punishment. I call it punishment. They call it cost sharing to the state, so that the state legislature would then be required to pony up that money. And order to keep your SNAP program, you're going to have to contribute. Our state would need to contribute like 150, 200 million because of the error rate that we have. So it's really important this year for DES. So member access has to get their computer system ready so that they're doing a good job with work requirements. SNAP, DES needs to get their computer system ready and their administrative processes ready to bring the error rate as down as low as they can, because we don't know who in January 2027, we don't know who the governor is going to be, and we don't know who the legislature is going to be. If we're working in an environment where it's Andy Biggs as the governor and a Republican House and Senate, and we get a $150,000 fine for SNAP, I can imagine the legislature and governor saying, well, so what? We're not going to participate in SNAP anymore because we're not going to pay that $150 million. It's a $2 billion program altogether with all that food assistance. So I think we have to do the best that we can to get the error rate down. If we can get the error rate down to 5% in our SNAP program, then we don't get a fine and we don't need a general fund appropriation to contribute towards the SNAP benefits that our low-income families in Arizona are receiving. So, so those are, I just wanted to highlight those, like, besides the lawsuits that James was talking about and all the other stuff, like there are administrative actions that have to happen at DES and at Access to help improve the situation so that when January 2027 comes, we're not putting ourselves at even more risk, rolling the dice that, you know, we've got Governor Robeson Taylor or, you know, Biggs that are not committed to the SNAP program. And I don't know, I haven't talked to either of them. The risk is there, especially if we have a recession that's caused by these tariffs. Like you can imagine them saying, they say it all the time at the legislature, there's no money, there's no money. They say it all the time. I could see them saying that about SNAP. And if Access doesn't get their act together with respect to reporting, people could meet the requirements in school or working, but not be able to translate that and get that into those state agencies. So I'll stop talking there. Thank you.
Thank you so much, Will. Before we move into questions, I just wanted to take a minute to acknowledge our panelists, and I'm going to go in order of which they spoke just for reference. So we started off with Leila Barraza, the Director of Arizona Area Health Education Centers, then moved to James Hodge, Professor of the ASU College of Law, Dr. Dan Derksen, the Director of the Arizona Rural Health Rural Center for Rural Health, and then Will Humble, the Executive Director of Arizona Public Health Association. Thank you all for your time as we move into questions. I also wanted to recognize that if this is a conversation that you're interested in following, not only is the Center for Rural Health's website and that toolkit a great opportunity, we will also be having our policy forum February 17th, and we'll put a save the date in the chat as well. So the first question that we see on here, well, actually, before I get to that, we are seeing some comments about the SNAP Ed funding and what the defunding of that has had for implications. And so I just wanted to recognize that. And then the first question is about the Rural Health Transformation Project. As noted, it asks for states to submit a plan for baseline funding, which is equally distributed among the states, and what the NOFO calls workload funding, which can vary among states and also from year to year. How could Arizona be thinking about this in terms of opportunities for addressing some of the impacts on the rural health that have been brought up? And I'll turn that over to our panelists. It is also in the chat. I know it's a long question, so if that's easier.
Yeah, I'll take a shot at it, and there's probably others that would want to weigh in. And we have, as I was looking through the participants, a number of experts who have joined us. You know, that there is an opportunity here for the state to do some really creative things. There's some opportunities here for the state really to address some unmet needs as well. So I'd say they're really taking a very considered approach to this and trying to really get from the communities and those affected most by this, in addition to health providers, also health systems, insurers, and others. What are the things that we could do between now and when these provisions kick in, where a lot of people are going to lose coverage? Because this is an opportunity between now and then to get us together. I'm glad Will brought up the issue of the information technology system, because that's so important for how we make more efficient and more accurate eligibility, enrollment, and redetermination for public benefits programs. And I'm really glad, Will, that you talked a lot about the Supplemental Nutrition Assistance Program and the important role of the Department of Economic Security in those processes for assisting individuals in getting the kind of help and information they need to enroll for what they're eligible for. So I think the state's taken a very a logical approach to this, trying to engage the various groups that need to be involved in their plan. I would really take a look at that request for information so that you can make your needs and your suggestions known through the access program to the governor's office as they prepare their plan. This is a big opportunity, not only for the 100 million a year that I'm quite optimistic that the state will get, assuming the continuing resolution funds this particular discretionary part of the federal budget. But it's also that other part, that 5 billion that will be determined on the basis of kind of the numerator and denominator data of our state compared to other states. Remember, Arizona's the 14th in population size, and we're growing at twice the rate of the national average. We're one of the top 5 states in our population growth, and one of the fastest growing population. What we don't talk a lot about, especially when we're talking about Medicaid, is our low-income elderly population growth is quite high. And one of the populations that depends on both Medicaid and Medicare, the dual eligibles, you know, what we call the Arizona long-term care system, ALTEX, that population is also going to be affected. And that includes both the frail elderly that required additional help and assisted living and things like that, but also individuals with disabilities. And many of us are very, very concerned about what some of these changes mean for truly our most vulnerable population and individuals with disabilities. So I think there's a real opportunity for the state here. There's a significant amount of funding available. And I hope that our plan is something that we'll be proud of and really does address some of these things that have been intractable challenges for us over the last 10 to 20 years.
Does anybody else want to weigh in on that question, or should we go to the next
I saw
one?
Will leave for his unmute there, so he wants to say.
No, I'm not. You're doing good.
Okay, well, Will, I do think this one is directed to you. It's asking about those errors in the SNAP system and how those are determined.
I don't know how they're exactly determined, but SNAP DES has been required for years to report their error rate. So it's like there's a process. We had the same thing in WIC when we ran the WIC program. So I don't know the details of how they measure it, but I know that errors are not just one-way errors. It's you've given somebody too many benefits or not enough. Both of those are errors. somebody who meets the qualification and is denied benefit, that's an error. Somebody you give benefits to that they didn't qualify for, that's an error. So you got to get there. If we want to avoid going to the legislature that we don't know the makeup of in asking for $150 million, which they might say no to, we got to get our error rate down to 5%. That's reducing it by 3.5% this year in 2026. So hopefully DES has all hands on deck to figure out how they can do this. And part of it is data sharing. So for example, I would envision if I was in charge of DES, I'd be like, okay, can we build a link into the Department of Revenue so that we can see into the DOR database so that we minimize the errors on eligibility for our members? What is our computer system? So there's a whole lot of processes that they would need to because it can be done. There's states that have their error rate under 5%. It's not impossible. I'll just add a tidbit on this.
I'll just add
What
something
state
to
has the
Will's
worst?
part on this is that there are very good companies that are very good at consulting. They're quite expensive, but really helping states improve their eligibility and enrollment systems, data entry field by data entry field. And they're going to have a lot of new data entry fields that they have to enter. You know, some of the top ones in the country, they get used a lot by states that do have error rates and where they need to be. Accenture is one, I think Deloitte's another, but there's other ones where the state can lean on. There's a little bit of federal money to help states make this transformation in how you do eligibility and enrollment for your public benefit programs. And I think it would be behoove us as a state, and it'd be prudent for us to look at those states that do have low error rates and what entities they use to help them get there. Because the department, for those that don't speak an acronym like Will does fluently, Department of Economic Security and the Women, Infants, and Children's Program and the Supplemental Nutrition Assistance Program, these are all public benefits that in New Mexico, when we did this, we really looked at a no wrong door approach, so that if an individual went into the system, the IT system, to enroll and they were eligible for these other benefits and really needed them, you know, that it happened. There was no wrong door. You could approach it from different ways. And that's a much better way than trying to deny people access to the public benefits they need, and then they have to be hospitalized or put in a nursing home or something like that, where easily they could have been managed at home by a direct care worker or others to assist with that in a far more, I think, cost effective, but more importantly, a better approach to, you know, the type of health outcomes that we want to see. So I think we could, you know, we don't have to all invent these things ourselves or try to modify a system that actually needs to be thrown out and a totally new one put in the Oracle system and go into something more contemporary, because as Will says, the penalties for this and what it will cost the state if we don't do it in the next 12 to 18 months are going to be enormous.
Yeah. Sadly, we couldn't get the exemption that Alaska got. Alaska has the worst error rate in the entire country, whether SNAP program, way over 10%. And Senator Murkowski in Alaska is like, I'm a no vote on HR1 unless you exempt us from the penalties on SNAP. And they're like, okay, done deal. So Alaska doesn't have to improve anything and they still don't get a fine. I just had to add that color commentary at the end. That was my job, color commentary. So we're at 2:00, but anyway.
Thank you so much. I think we have one more question and just maybe enough time to answer it. And Dan, this might be one for you to take the lead on. How might the Rural Health Transformation Project workforce component align with existing state workforce initiatives, loan repayment, etc.? And then how do they make sure that these are taken into consideration in these conversations?
Yeah, that's a really good question. I think it needs to align. We need to enhance existing programs. You don't have to start everything over. Let's really make sure that ones that have the data to say, this is really good stuff. This is best practice. This is one of the things we lead the country in. Let's make sure we do that and maybe learn from those types of things. There's maybe other states that have an example of things, but hopefully our outcomes are let's make sure we enhance the wonderful training that happens in Phoenix and Tucson, let's say, for example, in health professions training, with training that occurs in communities, so that we're automatically recruiting people from communities, growing our own, so that individuals who are much more likely to practice in areas of need are recruited and helped to be successful in matriculating in those programs, but graduating and then staying in practice there. So I'm hopeful that we can be smart, really clever, and innovative, especially about when we get this resource, we're building on existing, leveraging existing to really get much further along where we want to be some years from now. So I think that's a really good question and a good approach to how we might really leverage the type of funding that's available over the next 5 years to do this. I suspect if we can show some really good progress on this, that this Rural Health Transformation Program could be something that gets recurring appropriations and that it will continue into the future. I sure hope so, because rural needs it.
Thank you so much, and thank you to everyone that attended today. We will include the slides as well as resources in the follow-up email, so please use those as you feel, and then feel free to reach out if you have any follow-up questions that we didn't get to today. Thank you.
Thanks so much, all. Take care.
Thank you.